Imagine if the ultimate cure for painful intimacy wasn't found in a tube of temporary moisture
Mm,
or, like a prescription hormone cream,
right.
but it was actually hidden inside the microscopic messaging system of your own stem cells.
Which is wild to think about.
It really is. Today, we're looking at a condition that affects millions of women, but has historically been shrouded in this incredibly thick layer of taboo. I mean, we're talking about dyspareunia or painful intercourse.
Yeah, and for anyone dealing with this, the physical and emotional toll is just, it's immense. What we're really examining today is a profound shift in medical science. We're
Exactly.
moving away from, surface-level symptom management and diving into the actual mechanics of cellular repair.
And we've got a really fascinating stack of sources to guide us today. We are unpacking recent medical literature, so this includes data from the Anatolian Journal of Obstetrics and Gynecology Research, some really comprehensive clinical reviews on female medicine, and even the operational protocols from regenerative biotech clinics, like the Bioscience Institute.
It's a lot of dense material.
It is. But the mission of this deep dive is to see if an emerging, totally sci-fi sounding treatment called intimate exosomes can actually reverse the cellular damage that makes intimacy so painful.
Yeah, but to understand the repair, we first have to map out the breakdown. You know, you have to know how the machine failed for you in the first place.
Okay, let's unpack this because we all know the standard like 101 level cascade of vaginal atrophy, right?
Right, the typical hormone story.
Exactly. Estrogen drops. And that could be from menopause or postpartum shifts or even medical treatments. And then the vaginal epithelium thins out. Glycogen production plummets, the protective lactobacilli basically starve, and the local pH spikes.
We hear about that standard chain reaction all the time.
Right. But our sources highlight a much deeper structural collapse that honestly, it often just gets ignored, specifically down in the extracellular matrix.
Yeah, and that is where the real mechanical failure occurs. The extracellular matrix it's basically the foundational scaffolding of the tissue. And its primary residents are these cells called fibroblasts. Under normal estrogen-rich conditions, fibroblasts act as tiny manufacturing plants.
Just constantly working.
Exactly. They are constantly churning out collagen and elastin. They provide the physical strength, the flexibility, and the inherent moisture retention of the vaginal wall.
But when that estrogen signal disappears, the factory essentially shuts down.
The fibroblasts go completely dormant. They just halt production of those crucial structural proteins. And consequently, the tissue architecture deteriorates rapidly.
Wow.
Yeah, the vaginal wall becomes paper-thin, fragile, completely inflexible, and, chronically dry.
So when you introduce the physical friction of intercourse into an environment that has literally lost its structural integrity, you get microtearing.
Right.
You get severe burning, itching, and just intense pain.
It ceases to be a biological process at that point and becomes a purely mechanical trauma.
I have to offer an analogy here because treating this profound structural breakdown with, traditional over-the-counter lubricants, it feels a bit like watering a dead plant.
Oh, that's a good way to put it.
Right. Like, sure, the soil gets wet for an hour, but it doesn't bring the plant back to life. Standard treatments seem to just mask the symptom while the fundamental tissue remains completely broken.
That analogy captures the clinical frustration perfectly, honestly.
Mm-hmm.
A surface lubricant simply reduces friction in the moment.
Yeah.
It does absolutely nothing to wake up dormant fibroblasts or rebuild collagen scaffolding, restore vascular blood flow, or reset the local immune environment.
It's just a Band-Aid.
Exactly.
Yeah.
Even topical estrogen therapies, which, are the standard medical intervention, they frequently fail to restore that deeper cellular architecture for a lot of patients. If we connect this to the bigger picture, we are looking at a profound failure of cellular communication.
Because the cells just aren't talking to each other.
Right. The cells themselves have forgotten how to regenerate because they are waiting for biochemical instructions that are no longer arriving.
Okay, so if the core problem is that local cells have lost their regenerative instructions, the obvious question is how do we deliver a fresh set of instructions?
Which is the million-dollar question.
And that leads us to the star of our biotech sources today, the exosome.
Yes. So exosomes are extracellular vesicles, and they operate on a scale that is, well, it's difficult to fathom.
They're tiny.
Very tiny. They are nanoscale, measuring roughly 30 to 150 nanometers in diameter. To visualize that, you could line up thousands of them across the width of a single human hair.
That is insane. They are essentially microscopic shipping boxes wrapped in a protective double lipid membrane. But the really wild part is what is packed inside the box, right? Because they aren't cells themselves.
Right, they are entirely cell-free. Think of an exosome as a zip file of biological code.
A zip file. I like that.
Inside that lipid membrane envelope is highly active bioactive cargo. We are talking about messenger RNA, microRNAs, specific proteins, and specialized lipids.
And the sources get incredibly deep into the biogenesis of these vesicles. And it's not just the cell spitting out random cellular debris, is it?
No, not at all.
It's a bespoke manufacturing process. The way stem cells pack these exosomes is very deliberate. Through pathways like the ESCRT pathway, the cell actually curates the exact biological code needed for tissue repair.
Yeah. ESCRT stands for endosomal sorting complex required for transport. It operates like a highly specialized assembly line inside the stem cell.
Okay.
A series of protein complexes recognizes the specific healing cargo, pulls it into a budding vesicle inside the cell, and carefully seals it off, creating a perfectly tailored biological package.
But there is an alternative manufacturing route, right? The ESCRT independent pathway.
Yep.
And the clinical papers are full of jargon here, mentioning things like ceramides and tetraspanins.
Yes, specifically markers like CD9 and CD63.
Exactly. But for someone just trying to understand the treatment, why do those random alphanumeric codes actually matter?
Well, those markers are crucial for quality control. The ESCRT independent pathway relies on the physical shape of certain fats, like ceramides, and those specific tetraspanin proteins to naturally curve the cell membrane and pinch off a vesicle.
Oh, I see.
Because exosomes are entirely invisible to the naked eye, a regenerative clinic needs a way to prove they have actually harvested pure functional exosomes and not just, cellular waste.
They need a receipt.
Right. Identifying markers like CD9 and CD63 in the laboratory is the verification stamp. It is how doctors know they are delivering a potent therapeutic product.
Wait, I have to push back on something foundational here because I hear constantly about stem cell therapy for regeneration. If these exosomes are being secreted by stem cells, which is where our sources say the highest quality regenerative cargo comes from, my first thought is immune rejection. Why not just inject the live stem cells directly into the patient? Are clinics just trying to isolate the packages to avoid the body attacking the living stem cells?
What's fascinating here is that is the brilliant loophole of cell-free therapy.
Oh, really?
Yeah. When you inject live stem cells from a donor into a human body, you introduce foreign living organisms.
Mm-hmm.
The safety concerns there are massive.
Because your body fights it.
Exactly. The patient's immune system might immediately attack and destroy those cells. There is also the risk that live cells could multiply uncontrollably or differentiate into unwanted tissue types.
So the regulatory hurdles and physical risks for live cell therapies are just a nightmare.
Enormous hurdles. But exosomes bypass all of that. They provide all the regenerative signals and the potent healing instructions of a young stem cell without any of the risks associated with living tissue.
Because it's just the package.
Right. Because they are just biological code wrapped in a lipid membrane, they are highly biocompatible. They do not trigger immune rejection. They cannot mutate or form tumors. They simply drop off their instructions to the target cells and dissolve harmlessly.
Okay, so we have this incredibly safe, perfectly packed zip file of regenerative instructions. Let's get into the actual repair job.
Let's do it.
When a clinician introduces these exosomes to thinning, highly painful vaginal tissue, what do those instructions tell the local dormant cells to do? Like, how do we take that dead plant and force it to thrive again?
Well, the repair happens simultaneously across several different biological vectors. The first critical phase is angiogenesis.
Building entirely new blood vessels.
Exactly. The exosomes arrive packed with pro-angiogenic factors. The most notable is VEGF, or vascular endothelial growth factor.
Right, we see that one pop up a lot in the research.
Yes. This protein binds to the endothelial cells in the degraded vaginal tissue and literally commands them to start sprouting new capillary networks.
Which fundamentally changes the environment. I mean, more blood vessels mean an immediate return of robust blood flow, massive oxygen delivery, and crucially, a return of physical sensation to an area that has become numb or painful.
Improved vascularity is the lifeline for the tissue. But increased blood flow alone will not solve the physical fragility if the vaginal wall is still paper thin.
Right, the scaffolding is still gone.
That brings us to the second repair vector, which is collagen synthesis.
This is where those dormant fibroblasts finally get their wing-up call.
Yes. The microRNAs delivered by the exosomes specifically target fibroblasts in the extracellular matrix. These instructions override the dormant state caused by the lack of estrogen.
They tell them to get back to work.
They command the fibroblasts to massively ramp up the production of both collagen and elastin.
Here's where it gets really interesting, because I love how this works mechanically. It's like a microscopic construction crew showing up at a dilapidated abandoned house.
That's exactly what it is.
The VEGF is the master plumber, laying all new pipes to get the water flowing again. The fibroblasts are the framers, putting up fresh, dense collagen scaffolding so the walls don't cave in. They are physically thickening the tissue and restoring its ability to stretch during intimacy without micro-tearing. But what about the burning, the raw, itching sensation? Because a lot of dyspareunia isn't just structural, right? It's tied to severe local inflammation.
Right, and that is the third and perhaps most critical vector for immediate pain relief. The anti-inflammatory and antioxidant response.
Okay.
Exosomes don't merely rebuild a house. They put out the fires burning inside it. They carry specific molecules like superoxide dismutase, or SOD, and glutathione peroxidase.
The fire extinguishers of the biological construction crew.
Precisely. Those molecules actively neutralize oxidative stress. They quiet the hyperactive immune response in the local tissue. This mechanism is particularly vital for women suffering from chronic inflammatory conditions like lichen sclerosis.
Which is incredibly painful.
It is. That condition causes intense itching, white fibrous patches, and severe dyspareunia. By delivering SOD and suppressing that localized immune flare-up, the exosomes halt the active damage, giving the new collagen and blood vessels a stable environment to grow.
So by attacking the problem from all three sides, commanding new blood flow, demanding structural thickness, and forcibly shutting down inflammation, the tissue naturally restores its own moisture and its own acidic pH balance.
Yeah.
You aren't just lubricating the surface, you are fundamentally eliminating the mechanical causes of the pain. At a cellular level, the tissue behaves like young, healthy tissue again because it has literally been reprogrammed with youthful instructions.
The tissue basically resumes normal physiological function. It is an elegant biological solution to a very mechanical problem.
The biological theory is stunning, but, theory in a petri dish is one thing. I want to know how this plays out in a clinical reality. Our sources dive into the operational protocols. How are doctors actually getting these microscopic shipping boxes into the deep tissue of a patient, and what does the clinical data actually look like?
Well, at the cutting edge of this field, clinics are utilizing ADMSCs, which stands for adipose-derived mesenchymal stem cells.
So they are harvesting stem cells from human fat tissue.
Right. The stem cells are harvested, cultivated in a highly controlled laboratory environment, and their exosomes are meticulously collected, purified, and quantified into a sterile serum.
And the sources outline specific clinical applications, like the ExoFemale procedure from the Bioscience Institute and protocols using Aseplis IRLV treatments.
Yes.
But walk me through the actual patient experience, because you can't just rub the serum on the surface of the skin, right? The lipid membranes wouldn't penetrate deeply enough to reach the fibroblasts.
You're right. Surface application alone is highly inefficient. The clinical administration generally occurs in an outpatient setting and involves either highly targeted direct injections into the vaginal wall or topical application paired immediately with an energy-based device.
The literature specifically mentions pairing exosomes with devices like FemAlift, a CO2 laser, or Morpheus 8V, which is a radiofrequency microneedling tool.
Right. Those devices create thousands of microscopic channels deep into the vaginal epithelium. But they do something far more important than just physically aerating the tissue to let the serum soak in.
It's the heat, right. They are creating a thermal injury.
Exactly. The controlled thermal energy triggers an acute, localized inflammatory response. The tissue recognizes it has been injured, and local cells immediately start broadcasting distress signals.
They throw up a massive help-wanted sign.
Yes. And when the highly concentrated exosome serum is applied directly over those microchannels instantly after the laser treatment, the nanoscale vesicles travel straight down into the deep layers of the tissue.
Right to where they're needed.
Exactly. They are immediately welcomed by fibroblasts and endothelial cells that are already actively looking for repair instructions. The synergy between the mechanical device and the biological cargo accelerates the tissue regeneration exponentially.
I should note our sources also bring up PRP, or platelet-rich plasma, which seems to be the older, more well-known cousin to this treatment.
PRP is a very solid, established autologous therapy. A clinician draws the patient's own blood, spins it in a centrifuge to concentrate the platelets, and injects it back into the tissue to stimulate healing.
But if PRP uses your own biology, why pivot to exosomes?
Well, the limitation of PRP is that it relies on the quality of your own aging cells. If a patient is postmenopausal, their platelets carry the growth factors of a postmenopausal biological state.
No, that makes sense.
Exosome therapy, particularly from young, lab-cultivated adipose-derived stem cells, provides a highly concentrated, standardized payload of youthful regenerative signals. It is a much more potent, targeted, and predictable biological intervention.
Okay, I am entirely sold on the science, and the delivery mechanism makes total logical sense. But as a patient researching this, I have to play the skeptic for a moment regarding the clinical data.
Fair enough.
Because when I comb through our stack of journals, the dramatic evidence often comes from animal models. They talk about ovarectomized rats and macaques showing massive increases in epithelial thickness and incredible microvascular density, which is, fantastic news for the macaques.
Animal models are the necessary first step in proving the histological changes.
True, and there are human observational studies. The sources highlight a specific cohort of postmenopausal women utilizing a device called cephadrine.
Hmm.
It tracked their progress over a 5-month period, showing a notable attenuation of vaginal atrophy symptoms and massively improved tissue trophism.
Right.
But walk me through that timeline. What is a patient actually experiencing from month 1 to month 5?
So the physiological healing rate really dictates that timeline. In month 1, the primary shift is biochemical. The exosomes begin down-regulating the inflammation through molecules like SOD, so the immediate intense burning or itching starts to subside.
That relief has to be huge.
Oh, absolutely. Then by month 3, the VEGF has established a new microvascular network, so blood flow and natural lubrication begin to return.
Okay.
And it isn't until month 4 or 5 that the fibroblasts have churned out enough new dense collagen to fundamentally restore the physical thickness and elasticity of the vaginal wall, which is what completely eliminates the pain of friction.
So it's a progressive rebuilding, not just an overnight fix.
Exactly.
But even with that promising 5-month human data, are clinics jumping the gun? Like, are they offering this complex biotech to the public before massive gold standard 10-year human clinical trials are entirely finished?
This raises an important question, and the medical community is actively navigating that exact tension. You have to weigh the incredible safety profile against the logistical hurdles of a new frontier.
Right.
Because exosomes are completely cell-free, biocompatible, and do not carry the catastrophic risks of live stem cells, the adverse event rate in these early human observational studies is practically zero.
Because there's no live tissue.
Exactly. The body uses the RNA instructions, and the lipid vesicle simply degrades naturally.
So the risk of a dangerous physiological reaction is minimal. The real risk is whether the treatment will actually be effective.
Spot on. The true challenge lies in clinical standardization. Currently, different laboratories utilize different isolation protocols. How a lab purifies its exosomes drastically impacts the potency of the serum.
Oh, wow.
Furthermore, the global medical community is still working to define the exact optimal therapeutic dosing. We know the mechanism works, but figuring out precisely how many billions of exosomes are required per square centimeter of tissue for maximum repair is still an evolving science.
Which means if a patient isn't careful, one reputable clinic's exosome vial might be a potent biological repair kit, and a less scrupulous clinic's vial might essentially be very expensive water.
That standardization gap is the reality of any rapidly emerging medical frontier. The clinical results for treating dyspareunia are undeniably profound, but the field requires rigorous optimization. Patients must seek out highly transparent, reputable clinics that utilize sterile, strictly quantified exosome products with clear biomarker validation.
Like those CD9 and CD63 stamps we discussed earlier.
Precisely.
So what does this all mean for you navigating this information? If you or someone you know has been quietly suffering through the pain of dyspareunia, the medical landscape is fundamentally shifting beneath our feet. For decades, the only answer was to manage the inevitable decline.
Right.
Buy a slightly better lubricant, try a localized hormone cream, and ultimately just learn to tolerate the pain.
But the profound takeaway is that science is learning to discard the temporary band-aids. Through the targeted application of stem cell exosomes, medicine now has the tools to teach the human body how to structurally reverse tissue aging and mechanical damage.
It's incredible.
We're moving from managing symptoms to reprogramming the cells themselves.
But looking at the sheer power of this technology makes you wonder just how far this biological reprogramming can go.
It really does. If scientists can harness these exosome instruction manuals to perfectly rebuild collagen networks, restore blood flow, and reverse aging in vaginal tissue, it begs a massive question for the future of human longevity.
Oh,
Could we eventually engineer completely synthetic exosomes from scratch in a laboratory? Bypassing the need for human donor stem cells entirely, could we program artificial lipid vesicles to deliver customized youth instructions to any failing organ, a heart, a lung, a liver, anywhere in the human body?
a completely programmable, universally applicable biological repair kit. That is a wild concept to sit with, and exactly the kind of horizon-expanding idea we'd love to explore. Thank you for joining us on this deep dive into the microscopic messengers rewriting the rules of cellular healing. It is genuinely amazing to see how the future of medicine is arriving, bringing real structural solutions to problems we used to simply accept as an inevitable part of life. We hope this conversation brought you a little closer to understanding the incredible, complex machinery of your own biology and maybe just how close we are to keeping it running in perfect harmony.